Hello, everyone, and welcome. We're about to get started here today. Welcome to Mitochondrial Medicine 2022, our Child Ask the Mito Doc session. This is always an exciting session and one that we will be recording. The recordings are beginning right now. I want to give you just a little heads up on how things are going to go. That's maybe a little different than you've seen before. We will be accepting questions in a variety of ways. Of course, you all in the audience, we will be calling on you and asking for your questions. I have some pre-submitted questions that will get us started, and we will be accepting questions through a Zoom Q&A. So lots of people will be asking lots of questions, and that leads us to our panelists that will be doing some unusual things too. We'll have four panelists answering your questions live, and then two will be answering them via Zoom, and then we'll kind of switch it up. So without further ado, let's get started. I want to introduce our amazing Ask the Mito Doc panel. We have, I'm going to go in order of who's sitting with us. So we have Dr. Larson from Colorado. We have Dr. Latchman from the University of Miami, Dr. Sharma from the Children's Hospital of Philadelphia, Dr. Anselm from Boston Children's, and Ava Morava and Tamas Kozicz from Mayo Clinic. So I'm going to get started with a question that was pre-submitted, and I am going to pose this question. I will get started with you, Dr. Latchman. Do children grow out of Mito?
Okay, so the question is, do children grow out of Mito? So I'm pretty sure they do not. And actually, sadly, sometimes as they grow, more complications may arise.
The next question I'm going to offer to Dr. Larson. What clinical trials are coming down the pike for children?
Well, there's a couple ways to answer that question. So one is the clinical trials that are currently available. We had a really nice rundown yesterday afternoon. So there were 12 principal investigators and companies that presented the trials that they either have underway or have recently completed or have planned for the near future. Most of those are targeting adult patients and not children. However, that's not universal. So some of the trials were enrolling children. So that includes the pyruvate dehydrogenase dichloroacetate trial that Dr. Stackpool presented. The TK2 compassionate use study that Dr. Hirano and Zogenix presented. Both of those are enrolling children. And our hope going forward is that the trials that involve adults will then spur a follow-up trial that enroll children that's targeting the same mechanism.
Thank you. I want to go to the audience next. Do we have any questions for our two in-person panelists? Oh, don't be shy. Take advantage of this opportunity. I do have a few others. The next question I want to pose to both of our panelists that are answering live, as well as the Kozicz family. What about gene therapy? Have there been any trials in humans?
Yes, so we heard yesterday about GenSight. So that was a gene therapy trial for LHON. There certainly are other people in preclinical stages that are exploring other potential uses of gene therapy. I think the way to think about gene therapy is that you have to have a mechanism that you can target that way. You have to have a way to address the mechanism that's feasible with the viral vectors that we have and our ability to introduce a transgene into that viral vector and have it incorporated into the genome in a way that it's expressed in a useful way. You have to be able to get that to the right tissue. You have to get that to the right tissue at the right time in a patient that will benefit from expression at that stage of disease. So there's a lot of complexity, but each gene therapy technology that's developed has spillover effects and lowers the barriers to potentially using gene therapy in other ways. So the fact that there are many gene therapy trials in other metabolic diseases, ocular diseases, neurologic diseases, each one of those trials comes with learning opportunities and spillover effects that hopefully will pay off in the longer term for more mitochondrial diseases.
I think also, with time, we've learned for the few gene therapies that have been done, of course, with a multi-systemic impact like mitochondrial disease, we are guarded with our hope. What will we fix first? Or how will we target the tissues with the highest impact? So that is a huge challenge. And we are learning that it is best to educate our patients that gene therapy may be one of the research therapeutic opportunities, but it may just be one of. Keep an open mind that we still have to explore other options because it is difficult to target all of the major tissues that are affected. Right now, if a child needs a transplant, we will give a liver transplant in some of the conditions or a kidney transplant, and that fixes that specific organ, but it doesn't necessarily reverse learning difficulties or cognitive deficits. And so we have to imagine that it will take some time, but we are hopeful that we will take steps to at least try to solve the problem for the highest impact tissues.
Thank you. How about Ava, Morava, and Tamas? Do you have any comments?
I think it has been said, but maybe one thing that brings us also some more hope. We have to understand, that mitochondrial disorders can be caused by the nuclear genome variants, but also the mitochondrial DNA variants. And of course, in the mitochondrial DNA editing, there were some possibilities to cut out, defective, but then it can actually result some depletions and it may not be good. And I think we can be, I don't know if enthusiastic or a little bit, maybe careful, but enthusiastic that in the last couple of years, there were some really breakthroughs that now we can edit the mitochondrial DNA. So you can change single nucleotides within the mitochondrial DNA, not all of them yet, but I think we will get there. And for example, in male-os, there is maybe a possibility to correct, that single nucleotide variant in the mitochondrial DNA. And if we can do that, that would also actually open up, possibilities for gene therapy with all the caveats and sort of, cautious approach, what was mentioned, which is true for in general gene therapies. But what could also be a very good aspect of these ability that we can edit the mitochondrial DNA, which we did not have so far, that now we can maybe really design animal models, which was really a big, long-standing roadblock, in developing not just therapies, but understanding the pathobiology of mitochondrial DNA-related single nucleotide variants. So I think there is now really some very important steps forward in that direction. So that is becoming a possibility. When and how, of course, there are many things that we need to clear before we can do these therapies.
Yeah, I'll also say I'm remembering the session yesterday about the mitochondrial augmentation therapy. So that's really a form of gene therapy, right? You're introducing more mitochondrial genomes into cells and then reintroducing them into the body. So that's like a form of ex vivo gene therapy. So there are many different variations on this theme. And I think it just goes to highlight the importance of the basic science that we heard in the first couple of days of this conference, because it's only by really understanding the mechanisms of disease that we can figure out which of these many different gene editing, gene therapy, gene augmentation type strategies might be relevant for specific diseases. But it's not going to be a one size fits all approach. It's going to be biting off a little piece at a time as we gain the necessary understanding to tackle that particular subset of mitochondrial disease.
I want to check in with our audience. I see that, I see you, Desiree. Here you go. She's going to bring you the microphone.
Hello, my name is Desiree McGee, and I have a daughter with ears too, and I live in California, and a couple nonprofits and an ambassador for UMDF. My question to you is, do any of you currently study the MTARS genes, and do you have patients in your clinics with these conditions?
I'm sorry, did you say ears too? Yes. I do, but do you have a specific question? Because they overlap, but ears too is quite specific, I think, in two different phenotypes. One is very rapidly progressing, and the other, which could be very stable for years. So I have a patient who's like 15 and walking, talking, going to school, very stable for many years now. I think we have several patients. I don't know how you try to reach out. Maybe you can email us. I think our emails were shared, or probably that's the easiest if you email the panel, and then we'll try to link you.
Yeah, I have a couple comments for you. So I think one thing to think about is that that's one of the larger categories of mitochondrial disease in terms of patient volume now. And that was, that was almost unknown like 10 years ago. So, it's gone from being a very, very under-recognized entity to now something that's pretty prevalent in most mitochondrial clinics. And Dr. Renkui Bai presented the results of almost 2,000 whole exome sequences. One of the single most common diagnoses that he made was VARS2 within that cohort. So I think we've probably all had the experience now that we use whole exome and whole genome sequencing that there's a lot of patients with the ARS2 disorders. And I think that speaks to, kind of the purpose of this conference, which is to advance mitochondrial medicine on multiple different fronts. So, if people are improving diagnostic technologies and techniques, then we find out about a whole new category of patients that have a well-characterized mechanism. And then, there are basic scientists that can then tackle that mechanism, try to understand it in a way that might lead to, more opportunities for therapeutics. And then then there's a big patient population, and then that feeds back to the clinicians. And so it's kind of a virtuous cycle. And of all the things that we've heard about over the last few days, right now, we don't know exactly what it is that's going to, lead to those types of breakthroughs. But I think that's the value of this kind of interdisciplinary type setting.
Thank you so much. Next, we're going to go to a question that came through the Zoom Q&A, and Dr. Sharma will tell us the question and then answer the question.
So the question was about IVIG treatment, if it might help curb or stop neurological regression following inflammatory cascades or metabolic crises. I think IVIG definitely has a role in mitochondrial disease. I think we all are aware of immunologic deficiencies with certain mitochondrial diseases. So we do have our patients who especially have symptoms of recurrent infections or are within a mitochondrial disease spectrum where we expect that to have those evaluations, and specifically patients who have deficiencies. Very many of them would be on either subcutaneous IVIG or something they take on a maintenance basis. Some other applications of IVIG that I've come across has been where patients present with a picture of CIDP type of presentation, especially the POLG patients. And in those, we have tried outpatient IVIG infusions, and that has helped stabilize some of their courses. So that's been helpful. Another application, which is not done usually, but I've seen, is patients coming in with status and nothing else is working. That's something we've considered in our practice, because we're blessed to have a lot of medical docs within the CHAP system. Dr. Goldstein, I've seen use IVIG in those metabolic crisis status epilepticus patients occasionally. Of course, this is different for different patients and specific mitochondrial diseases, but I just wanted to touch upon that.
Thank you. No, we have a question in the audience.
So I'm Kathy from Salazar from Albuquerque, New Mexico, and my daughter just turned 18, and we are finally getting into a clinic in Colorado to kind of figure out what's going on, because we know that she has 5 mitochondrial deletions, but she has about 10 different diagnoses. The most overriding one being that she has pseudoobstructive gastroparesis. She's been on TPN and lipids for 8 years, and there is no sign of her being able to get off of them. My concern is we have to transition to adult care. We have to transition outside of a medical home. It's absolutely terrifying. We get care at the University of New Mexico. There's a medical school attached. I've already told all her doctors, I want a resident, I want a fellow, I want someone new that's really open to learning with us on how to take care of her. She needs multiple doctors, her biggest one being GI and neurology. All of this complexity started at 2 weeks old. And the other complexity is she's my adopted daughter. We've had her since she was two weeks old. So the terror right now for us is transitioning from pediatrics into adult care and having those adult practitioners go, mitochondrial, right? That's really what mitochondrial. And how do we continue to help her live with a quality of life that's so important to her? She keeps telling me, this is my life. It's okay. I can manage this. But we're also seeing the complexities starting to become more as she's getting older. So what do you tell a parent like me who has a child who's 18 getting ready to transition to adult care? How and who do I go to? Yes, I got to speak with Dr. Larson this week, but I mean, what happens next? Where are we going? She gets palliative care. We're on medical cannabis to help. I mean, we're doing all the things that we can to manage symptoms, but she is getting sicker.
So I don't really have a good answer for you, but I thought most of us pediatricians are following our babies till, or forever. So I don't really see much transition, at least with my patients. And most of the clinics allow us to take, just take the patients, even if they are already adults. I'm not sure how you guys do. I know CHOP is also seeing adult patients at in a longitudinal run. So maybe this is not the best way to transition, but at least the person knows your child very well and probably has enough context in the hospital to find the adult specialists necessary. I don't know how you guys are thinking about this.
I'm Dr. Latchman from University of Miami. I see pediatric and adult patients. Some of the patients from my Mito clinic are referred as adults, and some of them come as babies. Generally speaking, I guess I would ask you, who has asked you to transition? You know, is it your geneticist, your neurologist?
He's not willing to see her anymore.
So he has asked you to transition.
Well, he just plain old said, I can't see her. It's just, it's not possible. So we are going to Colorado this summer. We finally were able to get through all the doors to get into Colorado. But our GI doctors, like, he was very glad we were coming here this week, but I haven't heard anything that will help him help her. And her symptoms are getting worse. I mean, the GI symptoms are outrageous at times. She's cyclical, and we could kind of track the cycles: vomiting, diarrhea, both, calm, and then it would start all over again. Well, now it's just all of it all the time. And so pediatrics has told us we're going to need to transition to adult care within the next year or two. GI is thinking we need to transition now because he's just at the end. He's like, I don't know what else to do for her. Neurology and gynecology, which are two other areas that are being very affected. They're like, we can keep her for a few more years, so that's going to be okay. Sleep is also like, I can continue to see her as an adult because she's the chronic fatigue. And they had to recognize her as narcoleptic so she could get access to modafinil. So, I mean, there's just lots of things. There's so many complexities. But our two main doctors, pediatrics and GI, they're like, we need her to move on because we don't know how to help her anymore.
I
And
understand.
that's terrifying.
I know, I see your point. I think the approach is to try to address what she needs the most first, right? She will need GI first. And then maybe your GI, pediatric GI can try to help you find an adult GI that manages complicated patients like her. Truly in this arena that we are all involved in, we kind of have to dissect and figure out little by little which part needs to be addressed first. Otherwise, it's truly overwhelming. And I can feel that energy from you, that you are overwhelmed. And there is no easy solution. But eventually, I have to tell you, you'll transition one and then the next, and slowly. It will not be something you need to do in a week or two. Unfortunately for you, you're not lucky to be close to a center that sees adult patients. And I don't know if in the coming years there is any possibility of anyone coming to your area or even a state next by, right? Next door to you. I think the goal is to address what she needs the most now. And it seems that it's the GI. Probably genetics will not offer the most therapeutic options for you right now, other than trying to diagnose her, because you said she still remains genetically undiagnosed.
I think this issue of transitions of care is, there's never going to be an easy solution to this. So every geographical location is going to have kind of a bit of a patchwork solution. But so if I have patients with metabolic disorders who are in their 20s or 30s, and I admit them to the children's hospital, the pediatricians are comfortable taking care of patients with metabolic diseases. They're fine with that. But everything else about adult care makes them uncomfortable. And if I admit that patient to the adult hospital, they're fine with everything else, but the metabolic disorder makes them very uncomfortable, right? So it's a trade-off. And we try to make that trade-off in the way that's in the best interest of the patient. One of the things that I'm optimistic about is the specialty of medicine pediatrics, so people who are dual trained in internal medicine and pediatrics. And the complex care, primary care clinic at Children's Hospital has hired medicine pediatrics trained individuals to serve as the medical home for young adults with diseases, chronic diseases that started in childhood, and to bridge that gap over the course of, because if you transition everything all at once, that can be very jarring. But if someone can, establish care at age 15 and carry that through to age 30 and be the medical home and slowly transition to adult specialties over a decade, I think that has potential as a way to address this.
Thank you very much. It's time for us to do our switch, where we will have Dr. Larson and Dr. Latchman answering our questions online, and we will have Dr. Anselm and Dr. Sharma. And I think we're going to split you up. I will let you have your preference on who wants to do the typing.
I can do the typing.
Okay, and then we'll call on you, Tamas.
Mark, I just had one little thing to add to the
please do.
discussion just now. I think, so we're able to see our adult patients in Mito clinic, but where we run into the challenge is that once they're over 21, we cannot admit them to the Children's Hospital. So when they're admitted to an adult hospital where we are available by the phone, but there's only so much we can do in terms of their acute problems, whether that's GI or neurology or cardiology for that matter. That's why it's really important for them to still, even if we are seeing them annually or biannually in the Mito clinic at CHOP, we still need those patients to establish care with adult providers within different specialties. So over the years, they've tried to identify certain champions within those specialties at institutions across the street who do see adult patients, so that those providers are not completely new to mitochondrial disease altogether. This is, of course, a difficult process because people move, they leave, you have to find somebody new. But if we try to focus on their most pressing problem. So if we can find adult neurologist who specifically is interested in mitochondrial disease, we'll try and find them somebody, if headache is a primary problem, help them find the right headache provider versus a neuromuscular provider who might see patients with similar disease. I just wanted to add that part.
I want to add as well, at Boston Children's Hospital, we have a special program, the transition program, where we are being helped to identify specialists, different specialists for our patients who are becoming adults. We still try to follow some of our patients for a long time, and in some other departments and divisions, there are providers who are agreeable to seeing patients, but I agree that's become an issue. For example, I see a patient with mitochondrial disorder and I want to refer to endocrinology. This patient was not seen by endocrinologists at Children's before, but they won't see this patient because this patient is older than 21. So I have to find someone in adult community to see these patients. This is obviously is not a great thing, but because this program, this transition program was created relatively recently, and it takes about a year to consolidate specialists in adult hospitals around Children's Hospital to take over in some certain areas. I am eager to follow my patients till they're adults. I have patients who are 40 years old and so on. But yes, this is a big problem. Of course, also at Children's, we're lucky because Dr. Amel Kara is over there at Mass General. So for adult care, I can also refer to her, but this is a unique situation. In most situations, there are not that many places that will, take adult mitochondrial patients.
Thank you. I am going to look next at one of our other pre-submitted questions. Oh, this one was interesting. My child is so hyperactive, he can't fall asleep and just goes all day long. Isn't Mito a disorder of energy? Is it possible for him to have Mito in too much energy? Either of you or both?
So I'm sorry, I didn't fully understand whether the child is already diagnosed with mitochondrial disorder. Oh, so well, it is possible to have a child with mitochondrial disorder who has a lot of energy, right? It is possible. It's rare, I must say. So I don't think that this child is hyperactive because this child has mitochondrial disorder. It's probably a combination of underlying maybe attention deficit disorder and the mitochondrial disorder.
So a co-occurring
Right,
situation?
right.
Thank you.
Yeah, I think it's just important to understand that common things are still common. Just because a patient has mitochondrial disease doesn't mean they're not as likely to have ADHD as a general population. So if you're seeing symptoms that don't make sense with mito disease, it would be very reasonable to evaluate for the common issues.
So the question comes whether this child can be treated with stimulants like Ritalin, like other patients being treated without mitochondrial disorder. I would say yes. I don't see a problem with that. But each case has to be approached individually.
Any comments, Dr. Kozicz? How do we start the Mito cocktail with our young son? Do we give them all at once or one at a time?
I think that's a good question. What we personally tend to do, and I know this is not always possible, is because we have multiple components of the mitochondrial supplements, we've identified a compounding pharmacy who works with us. We compound all of the different elements into either a liquid or a capsule formulation. Most of these have to be dosed twice daily though, so we unfortunately can't reduce it to a once daily dosing, but that's how we tackle the problem. I know there are places where the compounding is not always possible and people are stuck with taking a lot of pills or liquids multiple times a day. I don't, of course, have an easy solution for that, but looking for a compounding pharmacy in your area who can work with your insurance would be step one.
I can tell you what I usually do because some of the supplements that we recommend have horrible taste. For example, vitamin B2. And so sometimes if I start a child on all supplements at the same time, child would just refuse taking the compound just because of vitamin B2 that makes this horrible taste. So I usually start with few. I think that ubiquinol is or CoQ10 is the supplement that all children have to be on. And so I usually combine ubiquinol with several antioxidants, and then if necessary, I renew the prescription with additional supplements if child tolerates. Then we continue that, but it is also possible to take something out later on.
Do we have any questions in the audience? Okay, I will move on. I have a third grader impacted by Mito. Due to COVID, we have been homeschooling. He hates remote learning and his grades are slipping. Is it safe to go back to in-person school?
I think we've definitely come across this question in clinic in different forms. First and foremost, yes. We have been encouraging our patients to go back to school in person if that is the best thing for them in terms of continuing their learning in the best form possible. We've also been, the other question that has come up a lot in clinic is, can they get their COVID vaccine? Which I think we had a good session about that, and we learned that it has actually been largely safe in our mitochondrial disease patients. So we've been encouraging them to get vaccinated and gain that precautious safety against an acute infection. So yes, I would recommend them to go back in person if that's what's best for them.
Yes, I totally agree. Even in the past, we always asked our parents to talk to the teachers, and if even before COVID, if they find out that there are many sick children with flu or GI problem in the class, to keep kids home, but you cannot keep kids home forever. And with COVID, that's the same thing. If there is an outbreak of COVID in the class, it's of course it's important to keep child home, but it is better for all children to go to school if possible.
Thank you. My child has had genetic testing, but we have not found the cause of his symptoms. He has many VUS, variants of uncertain, unknown significance. Are there any new tests we might try?
I will definitely try my best to answer this question. I know I have other geneticists on the panel who are more
Yes,
equipped.
and Dr. Larson, feel free to pipe in.
We tend to see this a lot. In fact, some of our main referrals is to try and understand whether a variant of uncertain significance is contributing to a patient's illness. We tend to look at exactly what that genetic difference is, what that means from a scientific basis, and if whether we expect that to be creating a problem in the functioning of the gene based on other pathogenic mutations that are located in that realm of functioning in the gene. Of course, the patient's clinical presentation in relation to that variant comes into picture, and we have to very carefully analyze that based on what information is available for that gene. So this is a little bit of a specific question, but we certainly have specific tests we can do to understand whether their mitochondrial function is affected or not. And in a lot of these cases, we'll proceed with more invasive testing like muscle biopsy, where we'll look for biochemical dysfunction, complex deficiencies, mitochondrial DNA depletion. So trying to understand whether we can find evidence of mitochondrial dysfunction and tie it back to this variant.
So I think there's a couple of important ideas here. So one is that you can't read too much into the fact that variants of uncertain significance were included in a clinical report. So if you do broad testing, there are going to be dozens or hundreds of variants of uncertain significance. And there's a person, a lab director, a PhD, molecular geneticist, who's using their judgment and their experience to decide of all of the dozens or hundreds of variants of uncertain significance, should I, as a lab director, highlight 1 or 2 or 3 or 4 or 5 of those for the clinicians and the family, because they have some, they look more potentially clinically relevant than some of the other variants of uncertain significance. And every lab, and even within labs, every lab director has a different threshold for when a variant of uncertain significance appears suspicious enough to include on a report. So the number of variants of uncertain significance on a report is a function of the workflows at the lab where that testing was done. It's not a characteristic of your child. So I think that's one important thing to know. As a geneticist, when I'm doing a diagnostic evaluation, the question that I always ask myself is, am I more likely to be missing a genetic diagnosis due to lack of breadth of the testing? Am I not covering enough of the genetic material or enough different types of genetic variation? Or am I going to miss a diagnosis due to lack of depth, meaning there's a pretty specific clinical scenario that we're in, and there's a subset of genes that we need to interrogate more deeply and maybe look more deeply into some functional studies of the relevant genes, some biochemical studies, maybe some of the more unusual genetic studies that we're just starting to be able to use, like RNA sequencing or methylation studies, things like that. So That was a long answer to this question, but I would encourage you to have that discussion with a geneticist. Is this a highly specific clinical scenario where we need to look deeper, or is this a non-specific clinical scenario where you might wait a couple years until there's broader tests available?
I see that Dr. Kozicz has some comments.
Thank you. What I wanted to add to your comment that how deep we go, it also matters what tissue we are evaluating. So if there is really a high suspicion of mitochondrial disease, then we might need to go back to the old-fashioned muscle biopsy and get sample from there, not just for functional measurements, but for DNA. And sometimes in some instances, for example, when you are missing a part of the mitochondrial DNA, you can miss that diagnosis if you only check in blood. Sometimes there is like a percentage of heteroplasmy, which is different in the blood, and you miss that. I think our labs are getting much better now and report that low heteroplasmy, but I did have a patient who actually I detected in different tissues, a skin fibroblast and buccal swab, but the heteroplasmy was below 5% in blood. So I think what I just wanted to say that a negative result doesn't rule out the diagnosis. And then depending on the clinical suspicion, there are many ways to go further and in depth what Austin said.
Thank you. All right, I'm going to move to are there any other audience questions right now? Let's see what else we have in our pre-submitted. Oh, well, that's it. I would like to ask a question of all of the folks that are joining us today for verbal response. Alicia, if you could bring me a wipe so I can clean this up and give this to the other docs. This is something that I find can stimulate a lot of conversation, but also I think is one of the things our families want to know. You all work with children. What do you think the next thing will be? The next thing that we'll be talking about with children, the next thing that will, bring our families hope, but also things for them to start looking into and learning about. What do you think that might be? And I can start with you, Dr. Anselm.
Yes, thank you very much. I've been doing this for such a long time. I can tell you that like the first meetings UMDF meetings we had, there was no talk about clinical trial whatsoever, none. And now we have entire day devoted to clinical trials. Of course, we need to admit that there are only few trials for children, right? The majority of trials we heard about for adults. So we certainly do hope that some of these trials, while started in adults, will ultimately translate either into trials for children or for treatment for children. But also let's admit that mitochondrial disorders, they do start in childhood. So why don't we have enough trials for children? So this is our hope, big hope that we will be looking more into trials for children. I was very encouraged hearing about Morava trial, about mitochondrial transfusion or transplantation that was done only for patients with Pearson syndrome, right? Now the few were done for patients with Crohn's syndrome, but they told that they might start doing the same thing for patients with other mitochondrial disorders, with Latchman syndrome disease and so on and so forth. So this is the greatest hope that we have, that ultimately there will be more trials for children and more treatments.
Thanks. Along those same lines, I think some of the pressing questions or concerns that come from parents who are trying to find the next best thing, the next best option for their child is gene therapy comes up a lot now that has become a tool for some other diseases. Now that we have at least one approved gene therapy for a specific condition. that I think is going to become a bigger conversation as well, along with clinical trials. Of course, the genetic causes of mitochondrial disease are so much more complicated, and it's a vast spectrum. So it will not be a one solution for all, but I definitely see that already coming up in conversation when we're seeing patients, and I think that will continue to be something to explore.
I'm going to go to Tamas next. I know you see things from maybe a little bit of a different perspective. You want to tell us a little bit about your background and then tell us what you're thinking?
Yeah, I do mostly research, in this field. And of course, it's very difficult to predict the next best thing because it can come from completely unexpected, whatever, corners of science. I agree that the clinical trial, I mean, what we see now here in this meeting is really encouraging. And although I see that many of these treatments are not yet in a way curative, they do not really address the root cause of the disease, but we learn a lot from these, and that may help us, also designing better trials, and that's also very important. But I guess that in the research, I also see, and going to the gene therapy part, what I already referred to, these new ways, to edit the mitochondrial DNA that could open really new avenues, for really treating a large group of mitochondrial disorders where you have the mitochondrial DNA affected. And I know that also at Mayo, there are many people, trying to find out all these avenues, though sometimes difficult because of the delivery of these gene therapy tools, into the mitochondria could be sometimes difficult. But I expect that here we will see a lot of development. And I also see in the field that how many more people at this point are interested and working on this field than it was maybe 10 years ago. And of course, there's always a critical mass that you would need, for significant progress in the field. But on the other hand, we have to be careful and also patient because it also takes some time.
Dr. Larson?
So I do want to echo what Tamas said in that it's really, really hard to predict where these breakthroughs are going to come from. But I do think it's helpful to look at other rare diseases and just what breakthroughs have looked like. So, for cystic fibrosis, that's a much easier disease to tackle than mitochondrial disease because it's a single entity. It's been characterized for decades. But the big breakthrough for cystic fibrosis came at the level of the protein. It came from understanding what that protein does and how to help that channel be more open than closed. Spinal muscular atrophy is another disease that had major breakthrough in terms of therapy in the last few years. And there's actually two very impactful therapies for spinal muscular atrophy. One is a gene therapy, one is an RNA-based therapy. There's new RNA-based therapies for porphyria. And importantly with spinal muscular atrophy, it also hinges on diagnosis. So being able to diagnose that disease very early on, so that's now been added to newborn screening because there's a window of opportunity to intervene. So our diagnostic techniques improving are going to open that window of opportunity for more mitochondrial diseases as we diagnose them earlier and earlier with more sensitive diagnostic techniques.
And maybe here just at one point that I think that is also very important. And if there is a big breakthrough, that would also help us, because it was already touched upon that I think still it is challenging to really 100% be sure and in the diagnostics of mitochondrial disorders. So we have, all these genetic tests. Of course, as it develops, and we test more and more people, we will more understand these variants of unknown, uncertain significance, but it needs also time and then a bigger mass of people, who are sequenced, but also, some very sophisticated, non-invasive diagnostics, and many people are busy with that. Let it be a biomarker, if you will. I mean, that's still very challenging. And I think that gives a lot of, again, a roadblock in developing therapies and also following therapies, because we're not always sure that we talk about the mitochondrial disorder.
Dr. Latchman, do you have any additional comments?
I think overall, they are, at least in my clinic that I'm starting, a few challenges that I'm identifying. And maybe in a broad view, all of us at our different centers have some unique challenges and some general challenges. One of the main general challenge is, how do we test the undiagnosed patient to give them a diagnosis if we cannot find the gene? What will be the most non-invasive or friendly manner to do it? In our center, we are trying to develop a methodology through skin fibroblast. It's not always accurate, and of course, it is a work in progress. Many children and parents of children do not want to undergo multiple muscle biopsy, not even one. And so I've come to terms with that. I no longer spend so much time trying to convince them, because I understand that on an emotional level, they really are challenged to understand why that needs to be done. Sometimes they change their minds in time, but other times I think I have to figure out a better solution. I have to be the one to come up with a different way that makes it easier for them to want to, take this diagnostic journey with me, because it is their child, and they are always weighing the risk and benefits of putting their child under anesthesia and doing biopsies. We have to train the new generation of mitochondrial geneticists and pediatric neurologists. There is no doubt. So that is also my second passion, because there is no way even the current group of specialists can probably do it alone. And that is my hope, that if we keep bringing awareness to the condition and encouraging other trainees that we train to become part of this challenge with us, to bring about solutions. I truly believe that, yes, in the next few years, we will have better solutions. But in the meanwhile, I do see many challenges that face parents, the affected children, adults who are affected as well, and the clinicians and researchers who are invested in sacrificing so much time and effort to try to find a solution.
Sure. I just want to add to that how important it is to include trainees at a younger level to understand mitochondrial disease, to develop an interest in it, and not just geneticists and neurologists who are presently, the primary people who tend to take up mitochondrial disease as their passion, but people across the spectrum, to really create providers for the patients who desperately need them. I think there's a dearth of providers who have a deep understanding of this disease process. I think that's incredibly important for people who are established in the mitochondrial disease community to pursue, for sure.
And maybe to that point, also at Mayo Clinic, we try to also actually introduce mitochondrial disorders very early in the medical curriculum. So, because that actually can answer that question, how you transition from a pediatric to an adult care. Because if we train, the medical students, already at very early, they might get interested in the mitochondrial disease and maybe becoming, neurologist or endocrinologist or gastroenterologist, and they bring that kind of enthusiasm into that specialty, and they would be able to train, not train, but treat all the patients, transitioning from a child to adult care. It is challenging because, medicine is very big and very broad, and then the training somehow always gets shorter. I don't know why, but we have less and less time. But we try to actually get some enthusiasm, in the medical students for not just for this, but other rare medical conditions, and that might help, training the next generation of physicians. So there are a lot of things where we need breakthroughs, so it's, we have to tackle many of these in the same time.
Thank you. It's time for us to wrap up, but I did want to check with the audience one more time to see if there was any question in the back. She's coming. She's bringing the microphone.
I'm wondering though, with all the questions we have about transition, if we could try to figure out a way to get an advocate from the medical community to help us with explaining to insurance companies when people transition to adult schooling and when people are transitioning, with new doctors, to help us explain to them what mitochondrial is and the severity of the disease, because I think that that's still a big barrier for the people who are supporting and the patients themselves on how they can continue to get services without all of the problems that go with it.
Yeah, absolutely. I think we should come with some more unified solution to this issue. We do have, for example, letters that we provide to our patients for emergency room visit, for this, for that, but we also need to create some letter or handout that every parents can give to their insurance, just with explanation what mitochondrial disorders are and what might happen if a child becomes an adult and has to go to adult specialists who are not that familiar. So absolutely, we are thinking about unifying all our recommendations. We already have some on UMDF site and on some MMS site and so on, but we will take this into definitely we'll work on that. I just wanted to add to the discussion that was already held, that the other hope I also have that insurance companies will recognize how important supplements are for our patients. I heard that even arginine is not covered in some situations, while it was proven that this is, and it became a standard therapy for patients with MELAS. So how come the insurance companies, they would cover for some reason carnitine and leucovorin? Why don't they cover arginine and CoQ10 and so on? And so each time for us, it's a battle. We have also standard letters, PAs, we have ways, but the response from insurance companies are unexplainable to me. Some patients get everything covered and some are not. So that's the other thing I think we really need to further address in our community.
Well, thank you to our panelists. Would you give them a round of applause? I think we had a very interesting conversation today. I believe they will be wrapping up the online questioning, and we will be, we'll let you go and make your way to your next session. Thank you all for joining. And hopefully we will see you next year in Charlotte for Mitochondrial Medicine 2023.